Thank you for making time. My name is Gladys Gachanja, and today we're coming to you from the 4 Points by Sheraton here in Hallingham. Now, rheumatoid arthritis is a chronic, progressive, and at times disabling disease. Now, those who live with this condition attest to the fact that at one time or another, it has affected their work, or their sources of livelihood, and at times even their family life. Now, today we talk about a condition that most people associate with older persons, but it can strike at any time. More on rheumatoid arthritis right after this fact of the matter. Rheumatoid arthritis is an autoimmune disease in which the body's immune system mistakenly attacks the joints. It affects the lining of your joints, causing a painful swelling that can eventually result in bone erosion and joint deformity. However, rheumatoid arthritis, which is also a chronic inflammatory disorder, can affect more than just your joints. Women are more likely than men to develop rheumatoid arthritis. There is no cure for rheumatoid arthritis, but remission of symptoms is more likely when treatment begins early.
In 1998, in December, I started becoming unwell. I had a lot of pain on my left knee. It started swelling, and my parents took me to a health facility around. Then I went, I was treated, I was given some painkillers. But the pain kept coming back. Now the pain started spreading in a few other areas. I could feel some pain on my hands, the lower part of the legs. Some people thought it was malaria. I was given some medication for malaria. So in 1999, around April, the pain was too much, and I couldn't bear. So they had to take me to a bigger hospital. That is when I was taken to Chagoria Hospital. That is where the doctors said it was juvenile rheumatoid arthritis. Then I was young, so it did not mean a lot to me because I did not understand what exactly that was. And what they told me is that it would clear. And it didn't. After completing that 1-year clinic, I felt no pain, and to me, and even to my parents and to everybody else, I was just okay. The problem had cleared, and I didn't expect it to come back any other time. Later in life, when I started having some X-rays, that is when I realized that it's not a problem that is just there, but something that is progressing and affecting me even in a bigger way. Currently, the drugs I'm taking, the 4 of them, none is sponsored by NHIF. Save for Kenyatta National Hospital, these other hospitals, you don't find these specialists like a rheumatologist. So a few other times you find yourself going to private clinics where NHIF doesn't even cover for you. I have dropped from school. In fact, I took 7 years to go through secondary school because, well, on one hand I'm sick, and this sickness now brings poverty. At home we have nothing. And even now that I work, you find I am in hospital, like it can't go past 2 weeks without me going to a hospital. Rheumatoid arthritis is a disease of pain. It gives you a lot of pain. You live with pain throughout. Not just a stigma from outside, but even myself, I feel weaker, I feel smaller, I feel inadequate compared to my peers.
So the conversation is rheumatoid arthritis, and to help us along with the same, we have Dr. Eugene Genga, who is a rheumatologist, and of course Kanana Kajuju, who is living with rheumatoid arthritis. Thank you for joining us on this conversation. Now, starting off, we have defined it as an autoimmune disease in which the body's immune system mistakenly attacks the joints. What causes this, Dr. Ari?
One, gender has been found to be in the science of the disease. It's more in ladies. 2, infection. 3, Two, there may be a small role for genetics, which meaning that if a family member has a history of arthritis, the risk of getting the diseases is higher. So in the background of the genetic and the gender, we have triggers. So triggers are things like infections, things like cigarette smoking have been found to trigger the disease process. But to be honest, the exact cause is yet to be known. What we do know is that the body's immune system, which are the police, instead of protecting you, is unable to differentiate between the normal cells and the bad cells, so it fights everything. So the rheumatoid arthritis, primarily it attacks the joints, though it can affect any other part of the body.
Speaking of which, how do you distinguish rheumatoid arthritis from other bone diseases like osteoporosis, arthritis?
Something like osteoarthritis is more wear and tear arthritis, meaning with age. Take for example like an athlete who damages the knee, years later can develop what? Wear and tear arthritis of the knee. Vis-a-vis for rheumatoid arthritis, it's actually very classical. Classical in what way? One is autoimmune. Two, the age is usually 30 to about 40, 50. Three, it's presentation, and the presentation is what usually distinguishes from the rest. So usually it's a disease that affects both sides of the body, meaning right and left, affects the small joints. And by affecting the small joints, we mean that it causes swelling, pain, and morning stiffness. And usually the symptoms are worse in the morning. As the day progresses, things get worse. Things get better, sorry. Vis-a-vis osteoarthritis, which actually means that when you have osteoarthritis, the symptoms are actually worse with activity.
Okay, so for you, Kanana, when were you diagnosed?
I had having the symptoms when I was 7 years old, but it was later diagnosed when I was 10 years.
And when you talk about symptoms, what were you dealing with?
The pain, the stiffness of the joints, also a bit of a skin rash. When I was very little, my skin would dry and walking would be a problem. So I was treated for so many other things before they could finally know that it was rheumatoid arthritis.
What did they think it was?
So they were just treating the symptoms, because ideally most small kids or young children don't suffer from rheumatoid arthritis. I was now put on home-based care, exercises and stuff like that, just so that my joints don't stiffen.
Some of those symptoms, for example, tender, warm, swollen joints, stiffness, fatigue, fever. I mean, sounds like you could be suffering from something else.
Symptoms actually are very, very distinct. In what way? A young person or just any person will come with joints affecting both sides, and primarily it's the small joints. Like for Kajuju was the hands, the wrist, and comes on both sides, right and left. And the patients will probably tell you also the symptoms are worse in the morning. So in the beginning, you'll probably feel a bit of fatigue or some stiffness, and then maybe take a hot shower, things get better. But I think one major issue we have with diagnosis for lupus is that, for rheumatoid arthritis, is that index of suspicion. Because like Juju took her 3 years. And actually we have data locally, most of our patients are usually diagnosed after the second year, which is very unfortunate. And it's because the belief is that some of these diseases are not available locally. And also for Kaju, even it was worse because she's a child. Yes. Everybody assumes arthritis is an old person's
disease.
Yeah.
Okay, and you talked about the fact that it first affects the small joints, but with progression, it can now start affecting other parts of your body?
Yes.
How do you explain this?
Rheumatoid arthritis is an inflammatory. So inflammatory is like a fire. So there are these things that push the fire. We call them inflammatory proteins. So these proteins that drive the fire can go to the joints, but also can affect your nerves. You come with numbness, can go to your eyes, can cause them blindness. I've seen one particular case, it's very unfortunate. Can go to your lungs, can even go to your skin and form nodules. We call them nodules, rheumatoid nodules. So it's actually the right word right now. In the olden days, we would say rheumatoid arthritis, but right now it should be more rheumatoid disease.
How did progression look like over the years?
It was harder, especially when I was younger. That's when most of it happened. So now you find my joints, my hand joints and most of my joints, Because of the pain, I didn't want to stretch them. At one point, I had squint eyes. It was corrected after, I think, after a short time. I think 3 years ago, I had hip replacement because of the osteoporosis, so they had to recorrect it. So at one point, if you're really taking care of yourself and all that, you're able to minimize on the progression. Sometimes it gets better. At one point, I wasn't on medication because it went to remission. So I experienced like 5 years without taking meds and pain, and then it comes back again. So, yeah.
Speaking of which, how come some patients actually go into remission, but for others, it's a constant pain and experience throughout the disease progression?
Those are some of the things we've been wondering, because patient 1 will do well, patient 2 may not do too well. So in the West, where they're a bit more advanced, they've been able to come up with the criteria, and they can able to tell you this patient most probably will do well, so will do badly. And why is that important? Is because of choice of medicine. In the olden days, the guidelines was blanket. One shoe fits all. But now we come learn that rheumatoid arthritis is different as per person. In the olden days, it used to be a pyramid, so an inverted pyramid. So you start small as you go up. But now the rationale is that you start hard and then do what? De-escalate. And these are some of the lessons we've learned over time.
All right. Now, they talk about the fact that when you're having a heightened experience of the symptoms, they call them flares. And it happens differently for different people. For you, what triggers the flares?
When it's very cold, your flares are just crazy. So you wake up in the morning. Sometimes you have so the joints are so painful, you're not able to walk, or your inflammation is crazy on different areas of the body. You can wake up with your hands so swollen, you're not able to do literally anything. So other times you even have now the fever, but then fatigue is crazy. So you really have to push yourself to do anything.
The most common actually is infection. Why? Because the disease process and some of the drugs lower the immunity, so it puts them at risk for developing infection. So usually chest is the most common, urinary tract infection is the next one. So we tend to really encourage our patients to get vaccinated, pneumonia, flu, because by getting vaccinated, you lower the risk for the infections. Other causes of triggers are stress. It's a very interesting phenomenon, especially in the setting of not just rheumatoid arthritis, but generally autoimmune diseases, that stress has been associated with triggers. And such patients, we advise them to take time off, rest. That way the symptoms get better. The last one usually is non-compliance. Some of our patients just don't take the medicine. Especially in the setting of Kenya, where we have our herbalist and all sorts of doctors and everything who promise you in 3 months you'll be healed. Usually they tend to veer off to that direction, and then what happens? They come back with the flare.
Okay. All right. Now, Daktari touched on the fact that one of the risk factors that predisposes you to rheumatoid arthritis is just being a woman. So when we come back, he'll explain why this is the case. We'll be right back. Welcome back to Health Diary. My name is Gladys Gachanja, still with Dr. Genga and, of course, Kanana Kujuju, and we are talking about rheumatoid arthritis. Now, Daktari, before we went to break, we mentioned that apparently women are more predisposed to suffering from rheumatoid arthritis. Why?
We suspect there could be a role of estrogen, because if you look at the ratio of ladies who have rheumatoid arthritis before the age of 50, vis-a-vis after 50, before 50 the numbers are higher. Actually, the ratio of female to male is about 9:1 before 50. After 50 is about 3:1.
And we've mentioned that the impact of rheumatoid arthritis can affect your work, your source of livelihood, or even your family life for some people. For you, how has it affected you?
It has affected especially my work. Sometimes you're not able to be very productive or not even be able to go to work at all. Some people say you're just lazy, you don't want to work. especially when you keep constantly saying you're tired and it's in the morning, so you show up at work, you're like, I'm so tired. They're like, Sometimes it's usually because also the medication also have a lot of side effects. So also on the infections, you get that you're not able to use maybe public toilets because of now the UTI and stuff like that. So then now they cannot be able to provide for you a special area for you. So you psychologically have to deal with these things because not many people understand and many people will say many things.
Yeah, and especially because of the deformity it comes with. Yeah, what have you heard?
So what I have heard, especially when I was young and growing up, some people actually thought it was maybe witchcraft and stuff like that. Some will look at you differently, others will say things that are hurtful. When you're young, you get a little bit bullied because you're not able to do most of the things that kids are doing, running around and stuff. Sometimes people now tend to like keep checking out my hands. So you feel a little bit comfortable. So you're like, maintain a conversation up here. So some you can be able to explain, others the way they come at you, you're not able to explain it in a better way.
Now, Dr. it has been said depression, anxiety, feelings of helplessness are some of the things that those who live with this condition face. Do you consider this even as you administer treatment?
You have to. You have to. Because if you don't deal with the mental aspect, you'll have problems there. Because mental aspect means you have to encourage them. Mental aspect, don't deal with that, they'll not take their medicine. So you really have to incorporate that. And even some of my patients, I actually refer them to a counselor because like what Kajuju has said, it's not an easy thing. And no offense, Africans are very, very rude. They can just come and look at your hand like this and say, what's wrong? We are very rude people and say very mean comments. So you really have to factor in all of that.
Okay, and now that we're talking about treatment and management, what do you consider?
For treatment, usually, like I said, there's no one shoe fits all. So the way I do it, I classify my patients. So we have good patients and the bad patients. And bad patients, not saying that they are bad, but in terms of how they're presented.
Severity?
Severity, yes. Yes. So let's say mild and severe. Then from there, I'll be able to choose the medicine. So if you're very, very severe, sometimes just go straight for the big drugs. If it's something mild to moderate, you can start with a combination of 2-3 drugs and then work up from there. So in terms of the treatment options, we have something called disease-modifying drugs. They're called DMARDs. We have 2 types. We have the conventional and we have the biologics. Biologics are a bit expensive, especially in our setup. So most of the time we'll start with the conventional drugs. The conventional are usually oral tablets. Patients who don't respond to those particular drugs or maybe in the very severe form, we shift over to the biologics. The major drawback are cost. Cost. Like infliximab is about 200,000 is every 2 months. One called golimumab is about 80,000. In the hospital, they sell it for about 100,000 and it's monthly. So in terms of sustainability, our patients, then they are supposed to be working, they can't work. The bosses think they're lazy, so probably on half pay on everything. They're telling the patient 80,000. So it becomes a very, very big challenge for our patient.
You've mentioned about the hip replacement. What else have you explored?
I am on meds. I do a lot of exercises and I also eat clean, basically. What you eat also impacts your flares or your general recovery as per if you're not careful of what you're eating.
Yeah. Okay, and Dr. has talked about the cost.
Most insurance covers, they don't want to cover people with pre-existing conditions, and if you are covered, you find that every year that they renew, they can double up for the same coverage. I've had people who other people who are struggling with the same tell me that they have to skip meds until they're able to. So you constantly keep taking painkillers just to manage the pain, to keep you going until you're able to come up with an amount to now buy a dose of 30 days. That means now once it's done again, now you have to have thought of a way to get that medication.
So are we saying NHIF doesn't help?
Not really. Not really. To be honest, not really. I think they can do more, because I think some of the medicines that we share, that we use, are also used in oncology, in cancer. Take, for example, like rituximab. In cancer, they will get it. Here in rheumatology, we will not get it.
Now, Kanana, you mentioned that you have to tiptoe around your diet because some of the foods cause the flares.
Yeah.
What do you tiptoe around?
Especially fatty foods, fatty red meat, and a lot of animal products except for the white meat. So you have to try and just, especially also milk, you have to really keep it on the bare minimum. Once you have figured out what works for you, you're able to now work through it.
So some of these fatty foods, processed foods, the refined foods have a lot of oxidants in them. So these oxidants have a way of setting up inflammation in the body, thereby worsening the disease. So actually we encourage our patients to take more non-processed, more fruits and vegetables that have a lot of vitamin C, vitamin E, that counteract the inflammatory process. The last thing which you mentioned there, which I like, was that you should learn your body. And I think that's what patients don't want to understand. By now you should be able to, like, if I take this food, this happens, so you avoid it, because every person is different.
Mm-hmm. Yeah. Now, to take you back to the treatment conversation, I mean, there are very few rheumatologists in this country, and I'm imagining that woman or man in Mashinani. How do they get help?
That's the challenge. That's the challenge. We are currently working with there's a local rheumatology body, it's called the Rheumatoid Society of Kenya. We've been organizing for a couple of seminars. We've also organized a couple of outreach programs whereby we are trying to empower the clinical officers, also and local doctors and the physicians, such that now they're able to pick up these patients early. If they are stuck, they can give us a call. If the patient is able to come to Nairobi, we can send them to Nairobi, send them a treatment plan, then we do what? To further them back to where they've come from. So it's not the best, but right now that's what we're doing. But currently, at least, the numbers have slightly improved. We have somebody permanently in Kisumu, is a Dr. Omondi. We have somebody in Eldoret. Beryl is there. Mombasa, there's somebody called Sophia. The rest are basically in Nairobi.
So how do you connect those who don't know even where to start?
Yeah. Well, I have recently created a Facebook page where, because of the mobile phones nowadays, most of the people are able to access. You get now people who understand what you're going through to be able to support each other. Also, we discuss now stuff like food, the treatment, the psychological, so that you're not, so that you're not there struggling, feeling like the world is about to end. Because also the recovery rate, when you're psychologically okay, if I can say that, is faster, your body starts healing itself to some extent in as much as you're taking the medication.
What would you advise those that walk in your shoes?
I would advise them to keep pushing yourself in every area that you do. Don't let rheumatoid arthritis define you, because that would be the end of,
What they go through is not easy. I can only imagine the pain they go through, the pain, the fatigue. If you have maybe deformities, how people behave and everything. So I think for them, just to encourage them. And if you're patient enough, good things will come.
Thank you for your time, and as you've had, the support system around those who live with this condition is so critical, because if they are mentally healthy, the rest then follows. We now take a look at the health tip.
So today I have two breakfast options, and this side here, it's a breakfast option for a person who is working out or a person who uses a lot of energy during the day. So here with me, I have a bowl of oatmeal porridge. I have a fruit salsa, and I have a samosa. And why oatmeal? It's because it has a lot of fiber, and this helps with digestion, and this gives you a lot of energy. So it also helps in constipation, and also it slows the production of glucose and sugars in your system. It goes well with a cup of hibiscus tea. That's an herbal tea. And this on this side, I have a lighter meal for breakfast for a person who's sitting in the office, which work is not too much. And my breakfast today for this person is fish fingers and some raw vegetables. And the fish fingers will give you protein, it gives you energy during the day because you're not using a lot of energy, and this will keep you full throughout the day. And also this you can take along with an herbal tea, which is my hibiscus tea.
Great insights on rheumatoid arthritis, and my take home today is, as much as there is available treatment and management, it is important for the patients to exercise self-care. Well, my name is Gladys Gachanja, and we have been coming to you from the 4 Points by Sheraton here in Hallingham. Until next